And we're going to keep this agenda brief. And I'm calling the meeting to order. It's whatever time. I can't see the clock yet now. 11:05.
After 11.
Okay. And we're not going to do the minutes and the financial report. So I sent them all out, email to everybody. All the documents, video, and everything are all posted on the officer page of our formal website. So between email and the officer page, hopefully you've reviewed this stuff. So I'd like a motion to dispense with the minutes in the financial report and accept them as sent out to you and reviewed. Can I have a motion, please?
Made that motion.
All right. Can I have a second?
I'll second.
All right. All in favor? Aye.
Aye.
All right. So we'll skip down that part of the agenda. No old business. We dispense with the old business. We use the review, but it's always in the minutes anyway. By the way, Betsy, our secretary, did a wonderful job of the minutes. Very specific, detailed, comprehensive job of the minutes of the 325 meeting with Benistar, with all the questions and answers all recorded in there from that video. I hope you had a chance to look at it. I know I've sent you a bunch of documents. I've sent you the question and answer compilation there, the compiled question and answer where different board members ask questions. I've sent you, I don't know what else. I've sent you so much stuff I don't. GoDaddy update there on GoDaddy on the timeline to implement all that. And all the Benistar documents you should have in your hands. All right? So listen, we've been meeting with Benistar for a long time. I went back and looked at emails, and I went back and looked at agendas, and going back to July, it was in our agenda in July of 2019. I had the first discussion, I believe, I might be off on this, but according to research I did this morning, 21, 2019. So almost a year we've been either meeting, discussing, looking at slides, going over documents, asking questions. And then I finally asked the board, please, let's put all the questions down on paper. Let's all submit them. And we did. And we got all the answers. Hopefully you've had a chance to look at those documents, all the answers to all your questions. This has gone on a long time, and I think it's time to finish up the due diligence and move on towards an endorsement vote. Now, that does not mean if you have your answers in front of you, and I'll put those up, but if you have the answers from Benistar to your personal questions and you feel you don't understand anything that was replied or responded to, then please let's ask those questions and cover that so you're comfortable and confident. And, you know, I don't know where everybody's at and their trust level, what they think about Benistar. This is an open, frank discussion. If you got any concerns or questions, I want you to bring them up because I'd like to finish this. I think we've gone on long enough with this, and I'd like to get this finished so we can move on to the benefits of offering this group plan to our members. A lot of benefits to it. And you know, I think that would be the number one question. I know personally everybody wants to know what's the benefit to me, but what's the benefit to our group? You know, what are they getting out of that? And we've discussed this and gone over their slides many times to show the benefits of working with Benistar. So I don't think we need to keep dragging this out, you know. But I want to hear from you. So is there anybody on the board looking at, I can bring up the questions and answers if you'd like to do that. Let me share that. Okay, are you seeing that on your screen?
Yes.
Okay. I mean, it's pages, folks. It's pages here. And the top of the thing was the original general questions I submitted, and I got the answers from Benistar in red. I've reviewed all those. I sent this out when I originally got the answer from Benistar, these 10 questions. I hope everybody's had a chance to look at them. And then as we go down here, then we start with Charlie and all his questions, and their answers are in red here. I don't know if Charlie's on, didn't come on. I haven't seen him ask for admission, so. So these are all Charlie's. Keep going down. These are all Charlie's. The red is, again, Benistar's answers to every question, every specific concern, question, whatever, issue, whatever you got, don't understand, confusion, whatever. The answers are here. The answers are here. Here's Connie's. Connie, you're here. Do you feel you have all the answers you need? Or is there anything you want to ask right now?
Well, I'm still not real clear that if a person decides to go, for example, I've got Plan N, and if I was to go into this group plan or whatever, and I decide later it's not for me, so I have to call, I guess, Medicare, somebody that can help me get back into a plan. Will I be able to get back into my Plan N, or can I get a Plan G? Will I have to have like a physical or a doctor? So I don't feel like it was very clear, the answer.
Glenn or
So, yeah, so as relates to that, if you're exiting the group plan, you can go back into Medicare Part A and B, and you can re-enter and pick up a Plan N or a Plan G. Those are of course available now. There is an important thing to note though. If you have a Plan F,
Right.
if you have an individual Plan F today and you leave to enter the group plan, or you leave to go to any other plan, forget about the group plan. If you just leave that plan, you may not be able to go back to a Plan F because Plan F is no longer supported in the individual market. So that's something to be aware of. But otherwise, making a plan change out of the group plan is actually a little bit easier even than out of the individual plan change. You typically can just do it the first of the following month. Sometimes if it's too late in the election thing, it might be the month after that. But it's very simple to do that, and you can come right back in. There is no underwriting or that can be imposed. There's no loss, no gain. The only way in which that would occur, where they could put in some sort of underwriting, is if you dropped out of Medicare, which is a very difficult thing to do once you've had the benefit. So all of these things are regulated on the federal level. So there's no risk there from a pre-ex condition circumstance. And a lot of these things, and I realize this is a complex area, and broadly you can ask a lot of questions. And I'm just going to offer this just for your consideration. There are a lot of things that are special circumstance that came up generally in questions. And we do have answers to all those, but they don't apply to 98% of the entire population. So, what if I live in Guam? What if I need to go to Puerto Rico? What if I don't have Medicare Part B? What if I'm an ESRD person? We can address each and every one of those questions, but for the majority of people, it won't apply. And the simple, rule of thumb for this: if you're exiting a group plan, that's a qualifying loss of coverage. You'll be able to enter into Medicare A and B. It's not up to us. It's not up to the insurance company. It's federal law. You can go right back in to make your election for whatever individual plan, another MA plan that's in the individual market, another Med Sup plan, as long as it's offered. There are, on occasion, a special circumstance like I just described with Plan F, which is no longer being sold in the individual markets. So that would be a consideration. But for the most part, those things should not be of much concern. Hopefully I've addressed directly your question, Connie, but also more broadly, just kind of the context of some of the questions.
Well, you did, but now you brought up another one, and I'll try to be really brief. So my understanding is that if a person doesn't apply for Medicare within a certain time frame, and you wait, let's say till you're 67 or 68, then you're penalized and you're charged more. So is that going to affect us because we're going to be losing Medicare, right? If we go to a group plan, that's the way I'm understanding that.
No, you don't lose Medicare.
Okay.
Medicare's an entitlement, and so if you qualify for it, again, we can talk about the most bizarre circumstances and incarceration and whatever, but you don't lose your entitlement. You are entitled to Medicare. If you have the 40 quarters and the whatever, you understand. So Medicare A and B, you can always elect back into. Medicare Part C, which we'll talk about hopefully at some point here in the not too distant future, is delivered through a private company. So it's delivered through an Aetna, Humana, an Anthem, whomever. And those plans are under contract with the federal government. They don't get rid of your entitlement to Medicare. They just provide a different payer, a private payer, to deliver those same benefits. And the advantage to the federal government is they contract for a fixed cost. But as part of that arrangement, the federal government has made sure that each beneficiary is treated no worse than any other beneficiary. If this is by law, no worse. Every single one of those benefits must be paid by law. Every one of those beneficiaries has a right under the entitlement to go back to regular Medicare A and B, and they would do so with the preservation of no loss, no gain, so no pre-existing condition, no limits on any of their benefits. So all of that stuff there's a federal framework for it. If you delay entering, as you suggested, there can be certain penalties, particularly around the prescription drug area. If you don't have qualifying coverage, there is essentially what is a tax. There's a surcharge for each month that you're not in it. There's a small incremental change. What's important to understand there is it's not a tax on the insurance. It's an increase in the cost related to the base benefit. So under CMS, Medicare has defined the minimum amount that's qualified to be a Part D benefit. Today, that cost is roughly, I think, around $35, $36. And there's an incremental increase to that amount. So if you're out and there's for a period of time and there's a 10% increase to that extra $3 would be essentially a tax on you for not being there for that period of time. So that's it. Again, it's a law. It's accessible. Has nothing whatsoever to do with whether you're in a group plan, an individual plan, what the benefit is. Has no relation to that. It's just the federal government saying we don't want a bunch of people just coming in at the point at which they need these benefits. So
okay.
Yep.
Thank you.
Okay.
And that baseline is referred to as credible coverage, which you should all get a notice of being a participant in a credible coverage plan every year. By law, that's required.
Okay.
Thank you.
Okay, Connie, you satisfied?
Yes, I am. Thank you.
All right, Bob, we're gonna move on to you. Is there some things that you feel you still need clarification or?
Nope,
No? You good?
I'm okay.
Okay, and I also sent Bob, just so everybody knows, I say right up here on top that he had some other questions that were pertinent to carriers, and I sent Bob that document from Benistar also. That had all the answers to those questions.
Yes,
All right.
thank you.
All right, good, Bob. Let's see who's next on the, where's Rodney?
Right here.
Rodney, I don't see your questions on here though. What happened?
I don't know. I went through it and I thought this is very thorough. I think they did a lot of homework on this and I'm pretty pleased with it.
Okay. Good. Stanley, you have any questions?
No questions.
Okay. Have you had a chance to review it? Does it seem to answer a lot of questions?
Everything I read, what you sent us, I think it answers anything I had any concerns about.
All right, very good. Brian and Betsy are both youngins. They're not there. Oh, no, Betsy, you are. Betsy, you do receive. What do you receive? You have health care on your own through your employment, right?
That's correct.
Very good. Very good. Yeah, I keep forgetting.
Now then, John, I just received in the mail today my Medicare. Being I'm under SSDI and under 65, I was automatically enrolled in Medicare and Part B, but I'm going to decline to Part B as I'm still under GE's insurance. It's kind of fuzzy, but you know, I was wondering, is there any way, since I'm entitled to this Part B, that I can get a hold of Benistar and see what they offer, even though I don't really need it?
Okay, Benistar, can you answer this question?
Yeah, so as I understand it, you are a under 65, and let me first state, forgive me, I don't want to ask in an open environment where you don't want to share personal information, but I'll ask it, feel free to decline it. You have Medicare eligibility, I think, as I understand it, as you offered due to a disability, and you're under age 65, is that correct?
That's correct.
And you remain as a participant in their active healthcare plans. Is that what you were suggesting?
Yes, I'm still under GE's healthcare plan until 65.
Okay, so you will not lose any of your eligibility or benefits or be in any way penalized for making the election to take Medicare Part B at the time at which you turn 65. You will still have your open enrollment period just like you would if you didn't have this additional eligibility today. So no need to worry about it. If you want, you can elect it. It obviously has a price associated with it. The pluses and minuses of it are that you have sort of seamless access to Medicare. It will continue to coordinate with the base GE benefits, and there may be certain circumstances where it offers you additional benefits. I haven't thoroughly reviewed the benefits for GE, but even without doing so, my general sense is there isn't much call for you to make that election today. I would wait until you were 65 before enrolling into the Medicare Part B.
Okay, that's what I plan to do. I was just curious.
Very good. Okay, I think I covered everybody on the board, right? I do believe I did. Glenn or Don?
How about Betsy? How about Betsy?
Well, Betsy, you're still in a plan through your employer, right?
That's correct.
But she could still have some questions.
But I don't have any questions. I looked it over.
So you're okay, Betsy?
Right.
All right, thank you. So now, Glenn and Don, I think we're ready to move into. You received all our profiles, our healthcare profiles. Initially, in my discussion with Benistar last night, I said, all of us are kind of, we're learning as we go. GE thrust us into this whole thing in the private healthcare exchange with VIA benefits, and all of a sudden we had to make choices. There was a lot of distrust, there was a lot of anger, there was a lot of fear, there was a lot of stuff going on that are we getting the best bang for our buck? Are they doing what's right for us? All this kind of stuff. And I almost felt, in talking with Benistar, this is my personal feelings, folks. I felt we've carried this on a long, long time, and I felt there's some suspicion or confusion or doubt or something going on that we keep dragging this on and on. But you have a right to have those answers, and you want to trust. If we're going to go with Benistar, you want to trust them, that they have your personal best interest in mind, but also our group, our members, the people we're going to be reaching out to in the future, that they have their best interest in mind. So part of that was, well, what can you do for us individually? And we provided those healthcare profiles. And So they're going to respond to that, but not going to respond to it on everybody's individual basis. They're going to respond to it, and correct me if I'm wrong, Don or Glenn, but in a general way and tell you what they have to offer. And I don't know if that's going to involve comprehensive benefit coverage specifics or cost. I don't know what it's going to cover, but I'm going to turn it over to you guys and tell us what you're offering us. What plans are you offering us, and what are we looking at, if you can, with cost, and how it will benefit us individually and our group. If you could do that, please.
Yeah, so thank you. Thank you for those intro remarks. And to partly echo one thing that you commented on, and then secondarily to sort of pivot away from that, I want to reemphasize one thing. So in the first instance, thank you all for all the questions. And as part of any due diligence function, they're sensible. Many of the questions were around technical things. What I would say about that is that those technical things, to the extent that they're used to elicit, our competence in an area, fine, and that's part of due diligence. But you shouldn't stop asking a question if you don't know something about a benefit or about a circumstance or a product or a context that has to do with the regulation. All of this stuff is very complicated. We understand that. You should continue to ask that. Those are more of an educational, informational, making sure that you understand it. They're not in the context of due diligence. They're in the context of making an informed decision about how you can best serve yourselves and the population that you're representing. So we welcome those, and we expect those questions to continue over some period of time. What we would like to do today, John, with your permission, is to walk through a specific proposal, which is illustrative, and it's not, we're not saying you have to do this. We're not saying this is the only way to go, but to show you, so you get an actual feel for how this might work. And there's two components of it. One component just illustrates what it would cost to do it, and the other will take you through how the benefits work in detail. So those things would be representative of anything that we might suggest in this group Medicare Advantage Part C area, and how it relates to what you've shared as a group, the individual plans that you're in, was very helpful. It's not surprising that you're basically, every single person is in a different plan, in a different circumstance. And by that, what I mean, it's a different insurance company. Some are in Medicare Advantage plans, some are in traditional Med Sup plans, some have prescription drugs, some do not, some have rich benefits, some don't, some have a high cost, some don't. That's going to be representative of not only yourselves, but every other GE retiree, because they're all out there making a decision on their own behalf, and we recognize that. For some of those people, the choices that are available to them today are adequate. Not only adequate, they're happy. And we're not looking to disrupt them. We're not looking to say to them, you must make this change, or you should do something that you're not comfortable in doing, or you should walk away from a circumstance that works for whatever need you have. So that we will find that there's some people who we think logically should make the change. And this happens all the time, right? They're in a Plan F and they're paying $400 a month to Mutual of Omaha, and they get the identical benefit for a third of that cost. And they still don't want to change because they're not comfortable. We'll help educate them. We'll help show them. But at the end of the day, if it works for their circumstance and they're happy with what they are doing, then that's the right answer in our mind. That's it. We're not here to sell them on some group solution or whatever. No matter how much better it is, no matter how much money it saves them, no matter how much the benefits improve. Having said that, there will be a population who will look at this and they'll say, these benefits are significantly better. They're significantly more robust. They're priced effectively for what I need, and they're better than what I've been able to do for myself. And so I want to consider doing this. And those are the people that we're trying to serve. Those are the people that we're trying to assist in doing it. So I can't tell you today if that's 5%, 50%, or something in between. of the people that review this. But whatever that is, that's the solution that we've been focused on delivering. Does that make sense to everyone?
Makes sense.
Yes.
Yep.
So I don't know. I sent this to you in an email, John. So it might be easier for you to share your screen if you just want to click on it.
What did you send me?
I sent it this morning. Just something about, or you can let me share my screen.
Yeah. Let me.
There's two-
That's what I was just going to do. Is let me stop sharing this. And let me find you here. Where are you? It says I kicked Don Trudeau out of the meeting. No, I'm only kidding.
But by the way, I have a question. How is everyone so well coiffed? I'm like, I you know,
I need a haircut, Dad. You kidding me? This
Don't
was
have
hot.
any hair, man. All I need is a wash rag.
If you see my hair in the morning, it's not pretty.
I actually thought of throwing on a baseball cap.
I think I'm going to try to get out tomorrow for a haircut. They're supposedly open down here in Florida now. We'll see. Anyway, Don, I just gave you permission, I do believe.
Okay, let me try it and see if it works. Can you see that?
No,
Nope,
Can you see that?
no.
nope.
Not yet.
But see you all right.
Hold on. Clicking the share screen.
Yeah, you got to click share.
Here's my issue. I have 3 screens, so I got to pick which one I'm sharing here. Hold on.
That's right. Now you know what I go through when I do this. It's like back and forth, back and forth. Where the hell is
I
that?
think I want to share screen 3 as well.
I'm putting up some dirty picture now.
You're a killjoy, John.
Can you see that?
Yes.
Yeah, there you go.
The Washington Post.
Okay, so it's the
Quick
Washington
news alert.
Post I'm sharing. It's gonna change it to
Lynn?
something else here. Boom.
Got
You see
it.
that?
Yes.
There you go. We got it now.
You got it? Okay. So,
Everybody see it? Can everybody see it?
Yeah.
All right, very good.
okay. So again, none of this, if your first reaction is like why Anthem versus Aetna or United Healthcare, just set that aside. If your first reaction is why 3 plans instead of 2 plans or 1 plan, set that aside. Your first reaction is why medical and pharmacy as opposed to just medical or just pharmacy, set that aside. So this is just illustrative of what we do. And this is somewhat similar to a very large other sort of group that we actually have worked with that decided this, and this is something that you might consider, and they're very similarly structured, you know, and same sort of scale and size nationally and similar sorts of concerns. So in any case, what we've illustrated here are 3 plan choices. And what I would recommend strongly for your consideration is not more than 3 plan choices. So if any of you have taken time to go visit Medicare.gov, you can see every choice under the sun. Anything that's an individual Part D plan, anything that's a Part C plan that's in the individual market has to be on Medicare.gov. And you put in your zip code, you can search for your medication, you can do all of those sort of neat things. You can do it through GE's VIA system as well if you're eligible to do that. Those things are identical. And what you will find, think about it yourself or think about any other person that you know, if you give them 5 to 10 choices, they can't make a decision. They just can't. It's so difficult to compare any of these decisions. So part of our role, and what I would suggest is part of your role, is to evaluate these things and to say, what are the things that are important to us? And so one thing you might say is access nationally to people that travel, cost effectiveness, robust nature of the medical plan, robust nature of the pharmacy plan. The themes of what you think are most important and that you're solving for the population that you represent are the things that I think you keep in the back of your mind as we're working through this. So here, what you see before you is a range of a couple of different plans. And for those of you who submitted, and there were a couple, 0 premium plans, the thing to bear in mind, and we could put in something either at a 0 premium or close to a 0 premium plan. We could make that as the third option, if you will, the lowest end option. But the thing to bear in mind there is typically for those 0 premium plans, they either have very little in the way of prescription drugs or no prescription drugs at all. So the first thing that you'll note in looking at this, even in the most robust medical pharmacy combination, which is the one on my screen to the far left, that has the highest price associated with it. The medical portion of that in this environment is under $32. So the medical portion of it is relatively inexpensive, yet comparatively, the pharmacy benefit is almost $192. And so you say, well, gee, you know, I see I think the most expensive plan under VIA is like $50 or $60. How can this be? And the simple answer is, this is a full benefit sort of approach to delivering pharmacy benefits. And it's something that they typically cannot get in the individual market, because it includes coverage for not only brand drug, but all sorts of specialty drugs and all of the very expensive drugs that just aren't listed on the generic roster. In addition to that, it fills in through the entire donut hole. And if we ever throw out a term that is not completely comfortable to your understanding, please interrupt. The donut hole is just in the prescription drug benefit in the Part D benefit, and Part D is what covers all of the Medicare pharmacy benefits that are delivered in the copay, card world, as opposed to in the hospital setting. But all of those pharmacy benefits are covered under Medicare Part D. And the donut hole refers to the portion of the benefit in the base benefit. And this is typically in the individual market the case where the beneficiary, are picking up a bigger portion of those costs. Now, the thing to remember is those costs are narrowing over time as both the generic and brand portions get closed somewhat through discounting that's mandated from the pharmacy manufacturers themselves by the federal government, but yet there still is some economic burden to the individual, and under these plans, it fills in all of that economic burden, and it fills in all of the deductible burden, and it fills in all of the catastrophic burden. So it works much like a commercial active employee group plan where you just have a copay and covers all of those. So that explains why it costs $150 more than your typical other plan. So who will care about that? Well, certainly anyone who many folks in the senior populations that we're discussing have brand name, have need for brand name drugs that they utilize for diabetic support, for heart, cholesterol, et cetera, and many other chronic sort of illnesses where they do that on an ongoing basis. Now, for some folks, and this was raised in some of the questions, they have access to a discount card, and GoodRx is a very reasonable representation of a discount card. And the question came up, well, can I use the discount card in conjunction with this? And the simple answer is, it's a little known fact, or not well publicized, but the answer is you can't use a discount card in conjunction with any federal program. It's considered rebating. Will anyone be prosecuted or face any threat for doing so? Likely not, but it's still against the rules. You are, however, free to use the discount card instead of your Part D benefits. And if today you are very satisfied with the 2 or 3 drugs that you take, and your generic pharmacy benefit on an individual basis solves for that, and your discount card solves for the one brand drug, and that's good, then that's a fine solution for you. You don't need to consider it. But for many beneficiaries, they don't have easy access or the discount card is not sufficient to address that need. And therefore, this will be something that they greatly recommend. And we can help pre-enrollment, pre-decision, in reviewing a specific drug that they take and saying what it will cost them out of pocket if they select this plan versus another plan, say the plan to the right, which has a roughly similar but slightly less robust benefit for the pharmacy benefits. So in what we're suggesting, we think that an important element to consider is to have a plan, at least one of them, that has robust access to brand and specialty pharmacy drugs. And the reason is that's something that an individual beneficiary will not easily be able to solve for in buying an individual Medicare product today. So that's something that we think would be an important consideration.
Let me ask you something. On the left column, you started with the left column, right?
Yeah.
Where it says LPPO 20P, $200 deductible. That deductible is as far as medical and pharmacy total?
It's just medical, just medical.
Okay. What is there a deductible on the pharmacy?
There isn't a deductible on the pharmacy.
Okay. Now you did say that it does cover brand name and specialty drugs.
That's right.
Okay, and does cover the donut hole, which is big, and I agree, because when we did our healthcare surveys, one of the things we saw was a lot of people were skipping medications or rationing medications. Our elderly, more elderly, late 70s, 80s, in that range, were skipping their medications, skipping doctor's appointments, skipping tests and procedures, and that is an answer to that. That is an answer to coverage in the prescription world, in the Part D world, I believe. So you're saying those drugs, those maintenance type drugs with chronic illnesses, that you mentioned, heart disease or diabetes or kidney disease or any of that, those are covered. Those drugs are covered at a brand name specialty level.
With a copay, those drugs are covered, and they include things that you are bombarded on TV with, Truvia, all the drugs that you see that are pretty much any drug that's on a television commercial is a brand drug. And those drugs largely are targeted at folks with chronic conditions. And so they take them on an ongoing basis. Again, this is not to say that there are no other solutions. There are plenty of other solutions. People who are beneficiaries under the VA, people that have low income thresholds, there are any number of other things. The point that we're making here is simply that if you go to Medicare.gov and that's your mechanism for solving it, if you're going to VIA and that's your mechanism for solving it, this will be a superior solution for it and something uniquely different than what you could experience through that portal.
Explain to me in the box up on top, what does LPPO stand for, 20P? What's that stand for?
I'm sorry?
The box on the top of that column where it says LPPO.
It's internal mumbo jumbo. You don't need to memorize it. It just means it's a passive PPO.
Okay.
With a $20 primary physician copay plan with a $200 deductible.
Okay.
Under it is a $15 generic, $40 preferred brand, $75 non-preferred brand, 20% copay on specialty. But again, you don't need to memorize the lingo or the jargon, because this is just illustrative for something that we've used. And what you'll see when I put up the next thing, we'll go into detail about it and we'll make a specific recommendation, et cetera. And then the jargon we'll try to leave to the people who need the jargon.
Okay. Let me ask the board now. Do you have any questions on these columns or what they illustrate? Or deductibles or the pharmacy or the medical? Does the board have any questions that they want to ask right now on this slide? What do you have up?
Oh,
So
I'm good.
So moving from left to right, the right, whatever that middle position is, that sort of greenish color, I guess it is. I'm not sure what color that is, but that different colored middle column, that is a lesser benefit. And what we typically try to do if you're having three plans is we try to say, look, the middle plan is the middle priced and it's the plan that we think should have the broadest appeal to people who are evaluating these options. And I mean, I hate to say it this way, but it's sort of like the kind of the plan that I try to push my mom into or something. I mean, it's it has some balance where it's picking up drug coverage. It might have some out of pockets a little bit on the medical or even on the drug side, but it's still relatively robust in terms of those benefits. And then furthest to the right are intended to attract folks who are saying to themselves, look, I do need coverage, but you know what, on a day in, day out basis, I just need it to be there. I'm not utilizing it today. I really am concerned about the economics of this. So when you look at it, it's less driven perhaps by the benefits than the economics. And because of that, I would say that perhaps even what we've illustrated here is too expensive. It's, perhaps that number, as I said, should be under $100 in total to appeal to those sort of folks. I don't think it should be zero, because there are some zero copay, no drug benefit plans that are available in the individual market. You're offering something here doesn't enhance that experience for them all that much. And certainly if you have no drug benefit, what does that do for them? Again, not very much at all. But perhaps there does need to be a slightly lower point for that. And if you're doing 3 as opposed to 2 plans, you'd like to have some spread in both benefit and cost so that people go like, this really is a difference. So if the benefits were substantially different between all the way on the left and the middle, but the price difference was $2, then no person should in their right mind take that other plan, right? So we wouldn't suggest it. It doesn't make logical sense.
Is there any
But if-
vision or hearing coverage in these plans?
Say again?
Is there any vision or hearing coverage in any of these plans?
There are some limited vision and hearing benefits, and we can make them more robust. We can make them, $1,500 for vision and whatever. We can increase these benefits, and we're gonna shortly turn to just going through these benefits as to what people think will resonate and be meaningful for folks in that respect. So there, in addition to vision and hearing, there are other benefits that are preventative benefits for active people, like silver sneakers. There are benefits that are transportation benefits. So benefits that allow you to, for non-medical emergencies, take a hired car to go get groceries or to go to a doctor's visit or whatnot. There are other benefits that provide supplemental sort of non-core Medicare benefits for beneficiaries, and we'll touch on some of those when we go through the benefits, and you'll see the benefit thing is fairly robust and detailed. But just thinking structurally about this before we leave here, again.
And this is Glenn. I'd like to add that these are Med Advantage plans, so they do allow themselves to have the extra benefit bells and whistles, if you will. As Don mentioned, the silver sneakers, the enhanced chiropractic, hearing, vision, podiatric services. Again, so we can mix and match and add those to them as the board sees fit. And something that Don touched on to John's question about the labeling at the top, we called it a passive PPO network, meaning the programs we're showing here allow for the member to go to any provider or facility that accepts Medicare nationwide without a difference in benefit. We saw from some of the surveys, some folks have an HMO plan. And in that regard, in the individual market, you need to go to that network of HMO providers. And if you go outside that network, your benefit could be greatly reduced. In this environment of what we're showing, members do have a network they can access that is published and listed, but they also are free to go to any other provider or facility that accepts Medicare, and their copays and benefit would remain identical.
Okay.
Thank you for that, Glenn. So just finishing this last final thought, and then we'll move on to the benefit, take you through that in some detail. If there is, I'm sorry?
I thought Glenn lost his voice. He wasn't speaking at all.
No, he's right there. So again, if there's going to be two, then you know how you're solving for it probably is a core benefit and a buy up is how we would look at it. If you're doing three, then there's a buy up, sort of a catastrophic and the core plan, and there should be significant spread in both cost and benefits between those things. So that's our general approach to it. And we try to keep it all within the same system, so someone doesn't say, oh, well, on this one, the network's completely different, and this one, this is completely different, because that just sows confusion and makes it more difficult for people to assess those benefits and make a choice for themselves. So let me say two other things very quickly, and then we'll move on to benefits, or I can take some questions on this. The first thing is, what you see here is we've illustrated January 1st, just so you know we're talking about into the future. Our actual recommendation is that you might consider doing something sooner and off cycle, such as September 1st. And the reason you might consider doing that is we can make rates hold for, instead of just 12 months, for whatever that is, I can't do it in my head, but 16 months, whatever it is, so that there wouldn't be another renewal in the 4 months after September. It would come in the following year. And that might sort of allow people to take some look at those things in that period off cycle, when they're not bombarded by all the open enrollment materials from both via GE and also the televised stuff that all starts up in October. That might be a more thoughtful way to approach it. So that's something we can talk about at the relevant time. And the other thing that I would consider is, who in fact are we serving today when we start this off? And so if it's a population of a couple hundred people that we're just going to, open this up, that's totally fine. And we start there, and we should think about, in my humble opinion, what they need. So if all those people are geographically concentrated just in one location, let's not consider the fact that there's 100,000 other people that someday we might want to do. We can do that in step two. It's just, if there's 100 people today that we're trying to serve, let's serve those people as best we can, and we'll start with the next thing when the next thing presents itself. And I'm not saying that we don't think about the next step, but let's do the first step, and then we'll do the second step when the second step is ready to go. So those are the two comments I wanted to make about that. Generally, I'll pause now to see if there are any questions about this overall structure, how we're thinking about it, what the rationale is, the sort of approach we're doing, anything of that nature.
Yeah, I think what would just what you just said, you got me thinking. Now, I've said this many times, that we know that basically there's 50, 60,000 people out there that are online, GE retirees or dependents. They're online, but they're not necessarily in any of our, the 8 to 10 Facebook groups or any of that, or in our group, our GE Retiree Benefit Solutions group, but they're out there. And I talked to you guys about geographical, and you just mentioned something about that. And their loaded areas, Erie, Lynn, different places, Ohio, Schenectady. There is locations that we can market and try to hit. But I agree with you that we should start small. We have a list. We have a membership list. We have a Facebook group, and we could start small with that and see how the response is, and see what needs to be fixed or corrected before we go out to the larger group. But this is all part of, in my opinion, it's all part of when we go forward in the marketing, what audience are we going to try to attain, and how are we going to approach them? Do you agree with that?
I don't know if you're asking the board or if you're asking me. If you're asking me,
Yeah, I
I
was gonna
basically
say.
do agree with it. If you're asking the board, I'll shut up.
Even the board can certainly respond, but I was directing it towards Benistar. But and I agree with you that I think we ought to start with the 1,900 that we have, or 1,600, whatever it is, on email, our Facebook page, which we have, I think, up close to 2,500 other Facebook pages where, if they allow us, we'll put an ad there. start looking at, all the marketing devices, ads and webinars and doing all that stuff. But start, like you said, on a smaller basis and let's see how it goes and see how the people respond. And then, if it starts to work out, we reach out to that larger audience, that 50, 60,000 in those concentrated areas. Do you know you're writing an email right in front of us?
Don, you're sharing your screen.
Oh, that's right. Yeah, well, whatever.
Another point I'd like to make, this is Glenn, is we, again, are aware and quite familiar with the RRA stipend situation, which many are eligible for, and many new entrants will not be eligible for. The point being is we look to market and communicate the final plans at some point, again, assuming there's a high, medium, and low option. We realize that in order to remain eligible for your stipend, your RRA, that you do need to pick a product from VIA. So medical and RX in each of these scenarios will be priced independently and unbundled, if you will. So if for some reason somebody likes the middle tier medical plan, but they're keeping their RX with VIA, they're free to do so. If someone likes the high tier RX plan and they're keeping their medical with VIA, they're free to do that. For those where that's not an issue or the stipend isn't in play, obviously then these programs can be bundled and the pricing can be inclusive of both medical and RX. But again, we're going to be aware that we need to break out through the different plans the two key benefits, the medical and the RX. Does that make sense?
Yeah, I understand. Everybody understand the board?
Yeah.
Yeah.
Okay, good. All right, you want to go on to the next slide there, Don?
Yes. Do you see, I'm just curious, do you see my screen background?
Yes.
Yeah.
You do. So this is my dad in 1958 when he was in the Air Force. Do you know where this is? You guess where this is?
Arizona,
It's in Oklahoma, that is right.
Oklahoma.
It's Mount Scott in Oklahoma. People think that Oklahoma's flat. But anyway, so my most fascinating thing about that picture, by the way, is the fact that here he is with some other Air Force buddies. He's wearing shoes, hard-soled shoes. All right, so let's move on to the benefits. So this is a sampling of what you would look at, and this is a summary of benefits. This is just one plan. It doesn't really matter. There'll be one for each of these plans. And the most important thing to understand about the Medicare Advantage plans that we're suggesting in this group environment is, first, they are Medicare Advantage plans, and Glenn emphasized that a few paragraphs ago. So rather than Medicare Part A being delivered directly by CMS, it's being delivered through the carrier. So for example, in this example, it's Anthem Blue Cross that's delivering it. And because it's Medicare Part C, every Medicare Part C solution has a network. But in the group environment, as long as you meet certain criteria, and I'll say something about that in a minute, you can have the benefits be identical whether you're in the network or out of the network. Some people refer to that as a passive PPO, a passive preferred provider organization. Some people call that an extended service area, but it means the same thing. It just means that there are people with whom the carrier has contracted who are in their network, and there are people who are out of their network who they are not contracted with, but who accept Medicare. And in this group solution, unlike what you can get at Medicare.gov or through VIA in the individual market, the benefits can be identical. So it doesn't matter. It doesn't matter whether you're going to the network or not in the network. It's just completely passive. If you want to go there, you're free to go. If you don't want to go there, that's fine. So what allows you to go into this? First, it has to be a group plan, which this is. And second, at least a minimum of 51% of the population must have access to the network, and there's some tests that determine that. And so we would obviously make sure that this group conformed and would be allowed to have this benefit. So With that in mind, what you'll see is an in-network and an out-of-network benefit, but they're identical in every way. You don't need a prior authorization. You don't need special permission to go out of network to get them out of it. You go, if the doctor accepts Medicare, it's just like, it works in many ways very similar to a supplemental system. So this works well for diverse populations in a group setting. It works well for people who travel, who don't want to be tied to a local HMO network in a state. It might be snowbirds going to Florida or Arizona or North Carolina, or who may be otherwise traveling. It is a Medicare plan, and like all Medicare plans, including the base Medicare and Medicare supplements, it only works within Medicare service areas. So that's the United States and its territories, Guam, Puerto Rico, et cetera. So otherwise, it's very similar. And to go back to Connie's original question, if you want to exit this system, you can. Just you elect out of it and you go back into the individual market, and you could go back into the individual market and select a different Medicare Part C plan, or you could go back in and elect no plan, or you could elect a supplemental plan. So this group plan is meant to improve their access to quality benefits and to give them broader options that are not available to them today, sometimes with benefits that are not otherwise available to them, and sometimes at pricing that is more favorable than what they might otherwise experience. So briefly going through this, and I'm not going to stop to go through every single one of these benefits, but they're categorized in sort of more almost the feel of a major medical plan. But in the Medicare world, obviously you have hospital and facility sort of charges, which are normally covered under Part A. Those are all built in here as well. And outpatient doctor services and other sorts of lab and that sort of thing, which are under Part B, and those are all subsumed in here as well. In this particular example, there is no deductible, not to confuse you, John, but I'm showing you a different plan than the plan that was highlighted in 3 before, for no reason other than this one was an easily available one to describe. We can have a plan with no deductible. We can have a plan with some deductible. As you saw in this earlier illustration here, this had a $200 deductible.
Right.
This one has 0 deductible, whether you go in or out of the network. And you'll see that the same thing flows through each of these things. You could have a copay admission, so you could have this copay suggest that the individual is responsible for $50 a day when they're admitted to the hospital, or you could have them with nothing, as this suggests here. And each of these benefits can be turned on or off, and they have an effect, obviously, on the pricing. Sometimes there's a reason for doing that. If you're, I'm just saying this not for the board's consideration in their own context, but just why would you consider this? Some plan sponsors have union contracts, for example, and they must have certain levels of benefits or not, et cetera. So anyway, we could turn off and on any one of these benefits, and we can certainly do them for making price and uniform benefits part of the equation. So here, under this little example, there is no copay for any of these actions. This roughly, if you're wondering, gee, Don, how much would this cost to have 0 on all these things? Well, for the medical portion of this, if you recall here, with this $200 deductible and some of those benefits, it was about just under $32. This one here is roughly around $85. So it's an extra $50. So it might be worth considering enhancing or getting rid of the deductible. On the other hand, many people seem to have a deductible. So whatever, we'll talk about that in further detail later. Again, here you can go in and out of the network, same level of benefits. The lab and x-ray stuff basically refers to how these benefits are connected to the underlying service. So if you are hospitalized, typically those things are performed in the hospital as opposed to sent out elsewhere, but that's more of a process thing. Same is true under just actual base Medicare. So there's nothing different about this, but it's just highlighting that difference. Incidentally, while I'm going to go through this somewhat quickly, John, this is in your inbox. Feel free to share it with the board and they can review it at their leisure. Again, these benefits that we're talking about here, some of them relate to things that would be covered under Part B. So the presentation here is integrating Part A and B benefits into a single description of these benefits. What you may not be able to see on your screen is this is actually 41 pages long. So I'm not going to, like I said, it's not possible to spend tons of time. But as you'll see in this, these benefits are extremely robust, particularly on the medical side. What's illustrated here, just to illustrate that you can have coverage for just about anything you can imagine that would be a Part A or Part B benefit. This is skilled nursing benefits. You know, whether they're linked to a hospital stay or not, home health care agency benefits. Again, these are all zero copay sort of arrangements that include DME, durable medical equipment. Hospice benefits are mandated under Medicare, so that's nothing really new or interesting. But as you go through all of these things, you'll see, in this case, this illustrates a $25 copay for an office visit with no deductible. Here we were illustrating a $20 one on this plan with a $200 deductible. So you can mix and match and play with those, and we can show you some different things. A lot of these other services, on this one, for example, this had a tele copay. This one's illustrating a smaller one related to certain services, related to office visits. So there's a telemedicine benefit, which in today's COVID conscious environment, obviously is an important aspect for a lot of people. Remote office visits in a HIPAA compliant private manner. You can do it by phone, you can do it by logging on, et cetera. Someone had asked in one of the questions about chiropractic services. Here, they're illustrated with simply a copay, again, in or out of the network. So the patient's responsibility is $20. The balance of it is covered. Again, some of these things can be taken out if they're not desired or they don't want to be in a certain base plan. Podiatric services, as you know, the reason that there's an asterisk here is Medicare doesn't cover all podiatric services. You can make the adjustment here to either mirror that, which would occur in traditional benefits, or you can have, like it says, foot exams and other diagnostic treatments, and you can enhance those if you wish. Again, this is access to mental health care services. Believe it or not, I would say in today's environment under COVID circumstances, this is one of the most important, benefits there are. Just think of yourself, think of people you know who are home confined and the lack of social interaction, the burden that places on people. We've seen that in high school students, but it's certainly true for senior people as well. So important benefits there. Again, these are outpatient, but there are inpatient benefits as well. I'm not going to hit on every one of them. I'm going to scroll through a lot of these things. So ambulance services covered here. We show a copay, but you can turn that on and off. Emergency care, again, we're doing this, ER access for $90 in or out of network. You can make that $150 if you felt that was more appropriate. Urgent care outpatient rehab, cardiac rehab is a big thing. Again, with a copay. All of these things are included. Durable medical equipment, people ask about, do you cover my, walker, et cetera, all those sort of things. They're described in detail in all of this sort of things. There's some programs that Medicare supports that are built out further here related to diabetes management, testing, support, all those sort of things. Those are things that people will want to evaluate for themselves, particularly if they relate to them today. Same thing with COPD and a host of other services, opioid treatment. Someone had asked earlier about vision care. Here in this thing, we're showing a set of vision benefits. These can be adjusted. They can either be enhanced or more restrictively related. Some are mandated by Medicare, so you must include the original screening and preventative visits. Some of these also have other related preventative disease visits. The eyes are very useful in that respect for treating a whole host of disease states and evaluating them early on, including diabetes, and including a whole host of other things. These are available with a copay to make the copay zero if that was interesting. A bunch of preventative services. I'm largely going to go over these quickly. bone mass, colorectal, HIV, STIs, immunizations. This is a question that comes up frequently. Medicare mandates that you cover a bunch of these immunizations at no cost, but not all of them. And I honestly can never remember off the top of my head which aren't covered, but all of the ones that are mandated, including pneumonia and flu shots, are covered here with no co-insurance, no copay. Get it done anywhere you want.
Wasn't there shingles in there at one time and then they took it back out with Medicare? Wasn't there coverage for those? Was it shingles? I believe it was shingles.
I'm gonna mislead you if I give you an answer. I don't know off the top of my head. I think that sounds right, but they keep tinkering with this. But in any case, you can have it covered as one of the things. So if you have Part D prescription drug coverage, some vaccines are covered under Part D benefit. For example, the shingles vaccine. There you go. So there's shingles. Some of the Part D benefit.
Oh, there it is right there. Yeah. Exactly.
Breast cancer, cervical, prostate, cardio, annual wellness visit. I don't know if people are aware of this, but this is a Medicare mandated thing. Annually, you can go for a wellness visit. There's also a separate preventative one, depression screening. All of these are preventative screening type things, lung cancer for all these specified diseases. Again, if John, if you share this with the board, you can go through it and evaluate it for yourself. And again, in many cases, you can adjust up or down if there's a copay or not. In some situations, it's mandated that it has to be no cost to the beneficiary. It's mandated by Medicare. So we look at those things. This is all related to kidney disease and ESRD. Medicare Part D drugs, to distinguish them from Part B drugs. Part B drugs are the drugs that are provided in a caregiving facility or in a doctor administered, or they're in one or two cases there are specific drugs named that fit into it, but this describes what they are and how they're covered with zero copay. So one interesting thing from this is when you evaluate these things for some of these, and some of these are fairly expensive, obviously, immunosuppressant drugs right here, osteoporosis injectables, some oral anti-cancer drugs. Some of those are very expensive. They're covered with zero copay under your medical plan because they're a Part B drug. So they're not a Part D outpatient drug. Blood plasma, et cetera. Routine vision. Again, this is a fairly limited benefit. Let me just make sure I didn't skip it. Hold on. Yeah, I did. Hearing, let's talk about that first. So here's like an overview of what a typical kind of basic hearing exam, fitting, hearing aids, and there's a small maximum limit of $500. That could be adjusted somewhat if it's desired to, to $1,000. It really, it's not the thing with some of these things is if you need hearing aids, then you definitely are interested. If you don't, then you're definitely not interested in them. So it's kind of you have to determine what the addressable market, what the addressable population you're trying to serve, what they need, et cetera. But just to give you some sense that there is in fact hearing aid and hearing related benefits, and these can be adjusted as well. They can be increased in terms of the maximums, they can be lowered in terms of copays, et cetera. So all of those are adjustable. Same thing with vision. This is a fairly limited vision benefit, but it can be increased. This is the supplemental routine, the supplemental foot care benefit that can be adjusted or increased as desired. Annual physical, same thing. These are the video doctor visits we were talking about with no copay. Silver Sneakers is a program you're probably mostly familiar with. It's access to a bunch of gyms and fitness centers on a zero copay basis. So if you're an active person, this will help you stay active at a bunch of participating locations nationally. There's a nurse helpline. Foreign travel, someone asked about the foreign travel. This is mostly just an emergency benefit, and it's mostly designed to get you out of the country you're in if you're traveling abroad outside of a Medicare service area. But again, this can be adjusted a little bit. This has a copay. It will provide coverage if it's an emergency, you have to be hospitalized. There are some limits, 60 days, lifetime here. This is something that's obviously appealing to travelers, which none of us are at present, but eventually, hopefully, we all will be. There's some community-based services that are embedded in this. So you might see the term sometimes SDOH, which is socially determined outcomes of health or something like that. I forget the name, but it's basically all of these things that are additional benefits that are provided that Medicare is putting huge resources in today to support things like making sure you can get out to the library, making sure that you have interaction with someone within your community if you're alone, making sure you have adequate access to quality good food. You could think Meals on Wheels, but this is a little bit beyond that, making sure that you have some interaction with food needs that you have, that you're able to get to the grocery store if you need to make sure that you have access to other mental based things. And I don't mean like impairment, like just meaning like I said, reading or playing games or being in a social setting. So a lot of these have big impacts. You see this is food deliveries on the healthcare of populations, so that you don't become sedentary, you don't become, for lack of a more elegant way to say it, you don't become a hermit, or, and because those impact healthcare quite a bit. So anyway, there are a lot of programs that support that are embedded in this. And then, as I was telling you before, Medicare requires, and this is the maximum out of pocket, every program that you put in, every copay, deductible, coinsurance, whatever, has to have a maximum. The entirety reflected here is $6,700. This can be brought down. Another common one is around $3,400. It's not that expensive to reduce it from $6,700 down, but it's almost impossible to get to this level of out of pocket. You would have to go to the doctor every day, take every car ride. You'd have to engage in activities that it's impossible to do to get there. So a typical out-of-pocket amount for even an impaired person utilizing heavy amounts of services where there is no deductibles, probably in the $500 range, something like that. So anyway, this is an overview. We wanted to share this with you. And going back to what we had talked about initially, even though the specific copay deductible amount is slightly different, each one of these things are identical in terms of how you access care, the general benefits that are provided, the same insurance company, the same ability to elect this coverage, et cetera. So all that's really changing are an embedded copay, a coverage limit on what it is in the medical area, and in the prescription drug area, how big the copay is, what your copay percentage amount is for brand drugs, et cetera. So that's essentially ends what I wanted to take you through in terms of giving you some sense of benefits. Again, John, I think, at the appropriate time, you should probably just share that with them to look at so they can formulate their own thoughts post what we said. But I'll pause now, and you can certainly bring up any questions or initial reactions you might have to what we've said. And thanks.
Well, this to me looks like just, it's like a summary plan description is what it is, what you just went through, that 41 pages.
Yes.
So, I think that pretty well describes it and tells what it covers. And as you said, a lot of things are adjustable as far as cost or copay. So I think that's pretty good myself. Does the board have any questions? I would definitely get this out to the board to look at. And does the board have any questions on anything that Don just presented on the 3 plans and the summary plan description there? Anybody?
Somebody make up a question. Just do it.
I'll ask one. Why didn't it include brain transplants up there with the rest of those? I could use one.
As far as durable medical equipment goes, does this include CPAPs and replacement of the filters and hoses and masks twice a year?
Great question. I don't know. Glenn, do you know off the top of your head?
Yes, it does include the machinery and replacement supplies.
Very good.
Great.
Connie, Bob? Rodney?
Nope. I've seen some of this before, being just now turning 65. So it's pretty much what I've seen also.
So, hey, I have a question, John Phelps. It's Mike Roberts. How are you? So now based upon our different meetings and what have you, and hopefully we've satisfied the board's questions, and if not, we'll continue to answer them. What is your process at your organization? Like, how do you guys now go, yeah, we want to move forward? No, we don't. I mean, is there anything else we need to do?
Right now, I think, like you said, you answer all the questions we've submitted. We've had a number of meetings to ask questions face to face. I think it's time for the board to, maybe look at this material that's just presented, take a chance to look, take a moment to look at that. But then after that, we take a vote to endorse or not endorse. And then from there, we obviously move towards marketing and the process and reaching out when we're going to start, all the specifics of moving forward. That's the way I see it.
Is that a formal meeting, or is that a scheduled meeting, or it just happens at your next board meeting?
Probably, what time is it right now? It's we've been going for quite a while. So
I have a question. I have my mic
So
turned
do
on.
I.
okay, go ahead.
Does these policies, all of these you're talking about, cover every single place that Medicare pays?
Great question.
The short answer is yes. If it's a Medicare,
At least.
if it's a Medicare provider, someone that accepts Medicare, then yes.
Thank you.
John?
That goes back to it's a group and it's Medicare, and anybody that takes it, there's no network, right, Don?
Well, there is a network. It just has the same benefit whether you're in or out of the network. So you could go on. I mean, if you prefer to go online and look up a network doctor or a network hospital, you are free to do that. It doesn't change the benefit amount. So if the copay is $25 to go look up Dr. Jones, who's in the network, it is $25 for Dr. Smith, who also accepts Medicare, who is not in the network.
I just
Got it. Thank
wondered,
you.
since you designed the policies,
Yeah,
I
and
just
this
wondered
is
to make sure that they cover every single area that Medicare does, at least.
yeah, that's actually by law. So the thing that's different with this, that's unique to group plans, is this ability to do it outside of the network. So, yes.
Yes.
Okay, so I'll just go ahead and bring something up myself. So on the medical part, I would stay with VIA because I'm only paying on the prescription, because I'm only paying $18.20 for my Plan D. So then let's say I want to go to the second plan, that's $10.89. That's what I would pay a month for this plan.
If you were taking just the medical benefits,
Yes.
yeah, and so that's a great question, and it actually brings up a point. So we've priced the medical and the prescription drug benefits in that screen that you saw separately, and we can make available, if it's the board's desire, a medical only plan.
Mm-hmm.
The intent here in illustrating those three plans was to have three choices. They would be bundled together. But you raise a good point, which is there's going to be a set of the population that's going to say, I only want a medical plan. So maybe that is one of the choices then. And if that were the choice, then you are absolutely correct. It would only be that $10.
Because, sheesh, I'd be saving a boatload of money, like a boatload of money for my husband and I. And I'd be like, how else can I spend my VIA money now? Not just kidding, but seriously.
Well, you can buy me presents, Connie.
So
Pardon me?
The thing I would encourage you to think through as a board, it's a great question, is when you're thinking through this, are there other people that are similarly in a similar circumstance to me? Again, it's great, and I want to help you, Connie, personally, right? But
Yeah.
as a board, our mission is to think through, okay, there are a bunch of people that are in that position, and I think there are, like you suggested. So that's a great thought. And then the question is, what other circumstances are people likely to run into that you can think of that we might want to be able to address? So if those come up, those are things that we want to factor into whatever solution we ultimately put forward.
That's the RRA factor, and that's the
Right.
65-35 split, and it definitely has to be addressed because you got, as I just said, you got a 65-35 split. So, there's 35% that don't, get it, but there's 65% that do. So therefore, they're going to be concerned about keeping that $1,000. Even if you're helping them, you'd have to explain to them that you're helping them tremendously in cost for them to even not worry about that.
Well, John, there are some people that are paying way more money than what the RRA covers, as you well know. Some exhausted by April, May. So even at $199, let's say their plan, the second one, whatever it was, $199, whatever it was, it still would be cheaper than worrying about getting the damn $1,000 because they're going to be paying clearly way over the $1,000 anyway.
Good.
So
Very good point, Connie.
G can just take
Yeah.
1,000 and shove it.
That was the point I raised earlier too, that, whether it's the high, medium, or the low options, they will be priced out separately for medical and RX because of the RRA, that someone needs to choose a VIA product. They can cherry pick which they want from those three options, whether it's just the medical or just the RX. But Connie, to your point, actually, Don and I had this conversation a couple of weeks ago. We were on the VIA site and looking at particularly the RX benefits for what people may be paying out of pocket in the individual market just for their brand drugs. Could definitely outweigh the benefit of the stipend. No question.
Exactly. They're so scared of losing that when they're going to save tons of money if they do it.
Yeah.
So I'm gonna bid you all adieu. I have a hard stop at 12:30, and I have to take care of myself for a second. But thank you so much, and you in Glenn's very capable hands. And if there are next steps, you'll share what they are. But I think we look forward to collaborating with you to get an optimal solution for the population you're seeking to serve.
Right,
Thank you.
Don. You're doing
Thanks.
good.
Stay safe.
You too.
You too.
Thanks, Don.
Hey, John,
Yes.
why don't we call a special meeting instead of having to wait till next month?
That's right.
I mean,
Yeah. That's what I was thinking.
Next
That's
week.
good.
Yeah, Connie. And
So,
it'll be short. It'll be sweet, folks. Just on board on our side here, and we will, bring up any kind of questions, confusion, clarification you need, and then we'll vote, and then we'll let Benistar know. And meantime, I guess this will fall mainly in my realm. Is that we'll start thinking about, and I've already started thinking about, and already offered ideas to Benistar about if we do endorse, how are we going to market this thing? How are we going to get it out? And as Don had said, I think it starts small, start slow, start within our group, what we have right there that's totally available, emails and group members, both on our formal site and on our Facebook. And let's start there and let's get it going and get our feet wet. And, if we approve, and we move forward from there. How's that sound to you, Glenn?
Sounds just fine. We thank you for your time today, as usual, everyone. Again, if any other questions or comments arise, please feel free to share them.
Yes, we will. And I'll get that document out, that file out to everybody. Okay.
hey, Mike, would you
Yes.
guys be opposed to having like a Facebook Live on our group one day so that you guys could kind of briefly explain it to the members? They can all get on.
Glenn, we're fine with helping promote anything that you want. Is, again, the only guidelines that we have to follow are CMS Medicare. As long as we're not in violation of that in any way, shape, or form, and it's something that we all agree on, and we budgeted the time, the money, whatever it is, yeah, we're down for that, because not only do we want to help your group improve concept that we're not reinventing Medicare, we're just introducing the group model to you guys, because you're also used to the individual model since you've been retired. But once you understand it, it's far superior. And I think we've really got a great story to tell. And the one thing that's lost on everybody, I think, because we never really talked about it, this becomes a great way for you guys to create unused revenue for your organization, because we will be able to get funds back to RAGE, back to GE Retiree Services, whatever you call it. I mean, there is an ulterior motive here. We not only want to help you, we want to show you how to make money with this.
Sounds good.
Sounds great to me.
Yeah, I mean, we never really talked about it. John and I and Nancy talked about it early on, but it's something that I just think it's important that you guys know this, because we're going to be partners.
One thing I did say to the board, listen, all our time together from 2016, I've always looked for something that'd be a tipping point for us that would bring in growth and membership revenue. And I believe this is it. And we update our website at the same time. And we have a professional website that'll interact with everything we're trying to do here and achieve with you guys in a partnership. I think it will bring in people. It will bring in members. It will bring in revenue and benefit us, because, I've said this to you guys personally, Benistar, and I've said it to our board. I'm tired of begging for money, and I'm tired of asking people to join.
Yeah.
We want to definitely be a part of that process where we can help grow this group and add members and revenue.
And Connie, the answer is yes. We're happy to conduct webinars. We're happy to record those, post them on sites, make them available for people to access and view at their leisure, time and time again.
She's talking about Facebook Live. Have you ever done a Facebook Live with a group? It's a private group. So if we're talking about sharing
John,
something, I'm sorry, what?
Anything that we can get so that our members can see what we're trying to promote is great.
Yeah, I know. We're looking at all kinds of marketing, and webinars is part of it, and ads and email distribution, and I didn't even think on that list. I didn't even think, because we've done it ourselves. Facebook Live, it is a good tool. It's an excellent tool.
Yeah, well, let's use every tool available. We have the internet, we have social media. This is the world we live in today, these Zoom meetings. So let's take advantage of it. Now that everybody truly is forced, everybody's forced to use technology today. So let's take advantage of it.
Yep.
People that were hesitating before now have to do this to talk to their grandkids. So everybody's online today.
Well, we'll have a special meeting, and we'll make our final, share our final thoughts and decide one way or the other, endorse or not. And then we'll get back to you guys, and we'll proceed from there.
Thank you.
Very good. Thank you for your time.
Thanks,
All right.
everybody.
Thank you, guys.
Bye-bye.
Thank you.
Bye, everybody.
Bye-bye, you guys. All right, so they'll leave, and just quickly, I'm going to just do this just very quickly, not to tie you up any longer. And thank you for spending the time. But the other thing is GoDaddy. I sent you all an email. Hopefully you looked at it from GoDaddy. Where the heck is it?
Sound good. Yes, I looked at it.
Yeah, and they've answered all the questions and stuff. And we're going to kick off May 20. Geez, isn't it in this agenda? I thought it was in there.
Yeah, it was
There it
there.
is.
I saw
There
it.
it is. You got a next step email. It had the timeline basically from them. I tried to refine that a little bit, make it more specific. May 26th, I talked with the design consultant. 4 weeks from there, we should have the 7 pages with sub-pages in there done. And then we move on to the next phase, add other things. We are going to have the URL, the GE Retiree Solutions. It took out benefits just to make it shorter, .org. It's going to be a whole new URL, internet address. So it's really, and hopefully it's going to be beautiful, and it's going to be user-friendly and simpler and all that jazz. So we're going to start that process. So that's ready to go. Connie's already, it did show in your expense report. Connie already paid GoDaddy. So for the hosting for 1 year and for the benefit redesign. So we're all set. We're all set to go, ready to go. Okay.
Sounds good.
Anybody got anything else? Because I don't want to tie you up. And thank you for giving the time. I know this was long, but I think we finished up. I think everybody agrees we finished this thing up. Now we make.
Well, can we decide when to have our next meeting right now, since we're all here?
All right.
We can just do it early next week sometime, just a quick answer question vote.
Yeah, let me move this. All right. Wednesday to Thursday, does Thursday the 21st, is that good for everybody? Same time, 11 o'clock?
Let me go look at the calendar there.
That's fine with me.
Sounds good.
Sounds good.
Good. And we'll finish this thing up and decide what we're doing. And if we endorse, we'll move on to the marketing and rollout and timeline. And I think there was a comment in one of the slides that they had to wait 60 days after endorsement or something like that. I think that's why when Don was talking, he said September, kickoff on September 1st or something. But he also tried to tie that to avoiding or not avoiding the open enrollment for Medicare. But we'll discuss that.
Well, he did
That's
say,
grandfathering the price or something.
yeah, and September is kind of a low season to sign up, so you have better choices there, the way we're talking.
Okay, good. You caught that. Good.
21st is fine.
All right, so we're gonna put May 21st, 11 o'clock. I'll send you out a Zoom invitation. We'll get this thing done, okay?
Sounds
Right.
good.
That's
All
good.
right, hey, thanks, everybody. I really appreciate it.
You're welcome.
All
We'll see you
right,
next week.
see you next week. All right,
Safe, everyone.
Bye, you guys too.
yeah, stay safe, everybody. Stay safe.
Yep, you guys
Yeah.
too. Bye-bye.
I'm gonna close it out.
Okay.
All right.